Mike Peterson is going to give us a presentation on Medicare education. So, thank you, Mike.
Thank you very much.
Can everyone hear me okay? Okay, well, pleasure to be here tonight. I'm Mike Peterson with Security Insurance Agency. I'm here tonight simply to do what's called a Medicare education meeting. And I'll get in more about what that is, but I would say the biggest goal I have in probably the 15 minutes or so I'll be here, talk about some unique things happening in 2019, and then also elicit any comments, ideas, thoughts that you have. I have it on later in the slide. Rest assured, I don't know everything, and no one does. So we can work together on it. That's a good outcome. So an educational meeting defined just basically means someone like me is completely harmless. Okay, the Medicare enrollment window is not open. If someone said, I demand a plan tonight, couldn't do it. So October 1st is when what's called the Medicare marketing window opens up, and that's when we can talk about some of the plans that are out there. But the actual enrollment gets into on October 15th, and we'll talk more about kind of how some of these changes in 2019 is affecting. Okay. Want to be sure everyone knows that the opinions that I express are really that of my own. I was invited in just to do this educational format, but obviously as I give some opinions, I'm not speaking on behalf of anyone else but myself, okay? And then the other thing we'll get into is a lot of frequently asked questions, okay? Does anyone have any questions that you want to start with? Because there are a lot of changes for 2019, a lot of things that have come in the mail. Otherwise, I can just go through my format. But I thought if anyone has anything that you want to start with, that'd be great too. No? Okay. So probably the number one thing on a lot of people's minds, and it's not affecting everybody, but one of the more common and one of the more popular sort of Medicare plans was called a Medicare cost plan. Okay, Blue Cross sold them, Medica sold them, Health Partners sold them, among others. And basically there was a law passed back in 2015. The acronym was MACRA. And part of that was basically in the year 2019, it was going to phase out cost plans in most areas. Okay. This is not something that a lot of our clientele loves. This is not something that we love because it's a pretty significant disruption. Cost plans are one of the more popular ones in the state of Minnesota, definitely. People say, well, my sister lives in Faribault and her plan's not being canceled. What's the difference? The difference is that the way the law was set up is that any areas that had at least 2 Medicare Advantage plans for sale then would no longer offer cost plans starting in 2019. Okay? That's why our area, for instance, is affected, and there are a few counties, for example, that are not. Okay? So, you know, a couple things, I want to be real blunt, like we try to be with our clientele. I mean, when they pass something that is deemed a savings to Medicare, what does that mean? If Medicare is saving, that means they are expecting us to pay more, bluntly. Okay? Now, it's not maybe as bad as that sounds, but I want to be candid with you. We believe, this is our thought, that our clientele, because of these changes, will be having to pay some more in 2019 in one of 2 areas. Okay, one area is premium. Okay, if I want to keep maybe the similar plan that I had on a cost plan, I might have to go back to a traditional supplement, which can be excellent coverage. Okay, I'll talk more about that a little bit, but it also is more expensive. The other option is that if I go to a Medicare Advantage template, those can be excellent plans. Okay, but those often will have a higher degree of cost sharing than maybe some of the plans people are used to. So again, that's our blunt thought, is that because of the changes, if it's touted as a savings for Medicare, if it's saving them on the side, it's going to probably cost our clientele in our area some dollars, which is too bad. You know, so the cost plan phase out for those who are losing coverage, and again, not everyone is, okay? But the cost plan phase out, we believe, are going to kind of require our clientele to make a choice. Think of it almost like a T in the road, okay? Our standard guidance and advice that we'll give to people on Medicare is that if you think of your needs as kind of being in 2 distinct columns, you know, doctors, hospitals, surgeries, clinics on one side, and prescriptions on the other, okay? And it's important that any of us take a look and see, hey, what's our cost driver? For some it's prescriptions, you know, for some it's providers, hospitalizations, whatnot. Others, knock on wood, say, hey, thank the Lord, I hardly ever have to go in. But the point being, you have to see where your cost driver is or where you think your potential cost driver is. What the majority of people in our clientele who have those cost plans, what they would do is they would use the cost plan to fit that one column of the doctors, hospitals, surgeries, providers, okay? And then buy a separate standalone drug plan for their prescription needs, okay? Now, not to confuse things, there are and there were cost plans that you could have a prescription drug rider with it, okay? And those worked fine, but the key is in most cases, not all, in most cases, people were best served according to Medicare.gov research, and I'll talk through that a little bit, but taking a separate standalone drug plan that met their needs along with the cost plan on the medical. Any questions, comments, thoughts? Okay. So, you know, the traditional supplement certainly does have its options. And if we want to talk about perhaps a little bit of a silver lining in this, is that, you know, if someone is in a cost plan, and we want to be really clear, people know this, you do have some rights. If you're in a plan that's getting phased out, one of the questions that comes up is, my health has changed, or someone will call on behalf of their mom or dad, hey, dad's health has really gone south, is he going to be able to get a plan? So one of the rights people have, by all means, is that if you are in a plan that is phased out, you have a guaranteed right to buy a plan anywhere that's sold in your area, and they can't say no, they can't turn you down or anything like that, okay? That's a good thing. Traditional supplements, you say, what's the good, the bad? If I start with the bad, supplements traditionally, and again, doesn't matter what carrier. This is, as a Medicare educational thing, when I was joking, I said I'm harmless. I am. It's illegal to bring sales material. It's illegal to bring business cards. So I'm just speaking in generics here. But supplements tend to be higher cost in premium. There is very little, if any, cost sharing. And one advantage of supplements, anyone here know what Part B medication is? Part B as in boy medication? It's not real common, but it is real expensive. There's a short list. You can find it, of course, on the internet, but some of the medications that are dispensed actually through Medicare Part B as in boy. The common examples could be rheumatoid arthritis infusions, okay? Another example can be some take-home chemo pills. Another example can be immunosuppressants. Those medications that are dispensed through Medicare Part B as in boy, as you know, are extremely expensive. And we'll have coverage for those, but I might have a plan that I have to pay 20% of that until I hit my out-of-pocket, okay? Now, it's still a great deal based on how much I'm getting versus what I'm paying, but that's still a lot more out of your pocket. A supplement will pay that in full, okay? It's like any tool, anywhere. You just want to find the right one. So generic advice is that if you are in a cost plan that's getting phased out, and if you've had the misfortune of needing some of this expensive Part B medication, it's kind of a silver lining that you can sign up for a supplement now, because the open enrollments that we're so conditioned to nowadays don't apply to the traditional Medicare supplements. And so if you don't sign up one when you're first eligible, or because of a qualifying event, if I want a supplement 2, 3, 4 years down the road, I would typically need to fill out a health history, okay? Now, I want to be real clear, please. This isn't a commercial saying you have to go to a supplement. We just want people to know kind of the framework and the landscape of what we're facing now through this next open enrollment. So again, that's one kind of a quick and dirty on the Medicare supplements. For those who take a supplement, most people then would want to buy a separate standalone prescription drug plan, unless someone might be eligible for meds through the VA or another program, okay? The open enrollment, typically you mention open enrollment, and people start rolling their eyes going, oh man, now it's when my phone rings and when we get stuff in the mail, and I get it. But I do ask people sometimes to just look at it a little differently, because it is an opportunity as well. I mean, if we go back, some of you maybe have been on Medicare for many, many years, you'll remember 15 years ago, I was pretty well stuck in whatever plan that I was in if I was on Medicare. If I was going to change, again, I'd have to fill out a health history, and typically I wouldn't be able to. So this gives people a tremendous amount of leverage and choice and flexibility, and frankly, it's a lot less threatening. Signing up for a plan for 1 year is not nearly maybe as anxiety provoking as if I say, well, I better take this one because this is what I'll be stuck with forever, okay? So, you know, if the plan that you're in is working, and if the plan that you're in is being offered next year, fine, roll with it if you choose. That's great. But otherwise, just remember, a lot of people have been helped significantly because of the open enrollment, okay? One other item I'd mention to you, it's a very common, and I even say very understandable mistake that's made, is that people will say, well, I haven't changed my drug list, and my Part D drug plan is still offering coverage next year. I'm just going to keep that. And that might be correct. But I would just ask you to think of the possible thing lurking underneath. Once in a while, the carriers get sneaky, okay? And even if you haven't changed or your drug list hasn't changed, if your carrier is offering a different deal, if they bumped up their deductible, or who knows what a formulary is. Some of you do, some of you don't. Extremely important. You could have a group of 5 people at a party all arguing back and forth. I have the best drug plan, it's Aetna. No, it's Humana. No, it's whatever. And the fact is, they could all be right, because it's all individualized basically based on what am I taking, okay? If I have 5 expensive name brand medications, for instance, the most popular plan in our area might be horrible for me, okay? So who has heard of Medicare.gov? Anybody? I'm glad. You know, we view it as one of the greatest tools available for people. And the reason is that obviously if you just get on a Blue Cross website, they just want to sell you Blue Cross, or you get on Humana or whatever else, obviously they're going to talk about their own company. But the beauty of Medicare.gov, I think, is that as complex as it can be comparing medical plans, it can be, I think, even more complex at times on the prescription side. So what this allows us to do on an anonymous basis is go in and say, hey, here's what I'm taking, here's my preferred pharmacy or two, because I can shop among pharmacies, and in some cases, not much difference. In other cases, it's pretty amazing. So that's a good tool to utilize as well. I put in my list, I hit a button, it says, hey, for next year, in order, what are your best options? What's my least expensive? And what it gives me is the number I think most anyone cares about, what's called the all-in number, okay? In other words, deductible, copay, premium, the whole thing. What's my all-in number? And then you can click on it, and it will give you a better detail on exactly how that breaks down, okay? So we rely on Medicare.gov tremendously. In my opinion, it's more valuable of a tool for the prescription drug only plans. It's still a good tool for the Medicare Advantage prescription drug plans, but it's not, I don't think they fine-tune that quite as well yet. There's still some drill down that you'll want to do, but it's a great starting point, very honest starting point. Is everyone aware of the donut hole being improved? I mean, yeah, so there's been a slow, gradual kind of phase out of the coverage gap or donut hole for the prescription drug coverage. Originally, it was set to kind of sunset in the year 2020. And the good news is that they just recently signed in and have kind of have escalated that forward now for 2019. So it's not going to necessarily benefit everybody, but for those who have a pretty heavy prescription benefit, that can at least delay or even prevent or delay until I'm going to hit my catastrophic max. So that's also, I think, one bit of good news for next year. Inpatient versus outpatient or observation. I put a handout there. It's just printed out from the Medicare.gov website. But you know, that's something that we are seeing kind of rear its head in a few different ways for our clientele. One of them is that, for instance, let's say I have an injury and I have to have surgery, and all of a sudden now I'm going to be going into nursing home and try and rehab and get stronger. You know, to the extent if I was hospitalized and if I wasn't admitted, if I was in more under observation and so on, I'm still going to have coverage under Medicare, but it can certainly affect whether my rehab is paid by Medicare or by myself. And that's not an insignificant dollar amount. And I don't know the nuances of the coding and exactly when or where. All I know is that I think a lot of times, like anything in life, we have to be an advocate for ourselves or for our families. And so to the extent if ourselves or a loved one is in the hospital, I think certainly asking about the admitting issue asking about being an inpatient to the extent if that's possible can give you a lot, can save you a lot of money on the bill as well as for a potential rehab stay. Secondarily, this has been something really more common the last couple years. And when I say this, I'm not being critical except for this one item, but what I'll say is that a lot of clients have been getting these nuisance bills. And what I mean by that is that they're in a plan that they shouldn't have any copay, let's say, and they come in and they get a bill for $380. What the heck is this? And what we're finding, it took us longer probably than it should have, but what we're finding is that if people are at the hospital but have not been admitted, in other words, they're under observation, then what happens is that the medication that's dispensed is not paid by Medicare A because they're not admitted yet, okay? And so then that medication could and should be submitted to one's drug plan, okay? Now, again, I want to be clear, I am critical of them on this issue, but the problem I have is that our clients are just getting a bill. Very little explanation. Okay. And so what happens, well, obviously with HIPAA and whatnot, us agents don't have a lot of authority, if any authority, but if the client's on the line, then they'll talk to us. And so what we'll find is that, and I don't know about other providers, but is that our local provider, for instance, they don't submit to people's drug plans. They'll submit to Medicare, they'll submit to the medical side, but they won't submit the prescription part. Should they? My opinion, yeah. Of course they should. They got the technology. But my next point is, if you're not gonna, and I've said this to them so many times, and obviously I have zero input here, I said if you aren't gonna submit it, even though you should, then what you should do is send out the proper codes, because here's how it happens right now. You don't mind me using an example? Paul. Paul comes in to see me and says, hey, I've got this bill. We have to call the medical center, and they say, yeah, whoops, that was for a under observation prescription. I said, okay, but we can't file a claim for this person because you didn't send out the proper codes. So then you have to call the medical center, wait for another letter to come out that has all the requisite codes that you can use then to do a manual submission. Very time consuming, and what concerns me, I wouldn't even want to guess how many people in this community have simply paid it. Yeah. So anyway, I've felt pretty strongly about that for a long time because I think it's just a terrible disconnect on a communication piece. But just be aware of that, you know, in whatever plan that you're in. I'll go through this quickly. I know there's other things on the agenda. I don't want to overstay my welcome. October 1st, as I said, is the marketing deadline or window, so you can start seeing things on the plans. October 15th is when it opens. Standard advice I'm giving you, and I don't care where someone goes, if you are in a plan that is getting phased out, I would get in sooner than later and pick a plan. Remember, if you sign up for something on Halloween, October 31st, and all of a sudden you have regret after Thanksgiving and you want to change it, you can, okay? But with as many people as are losing coverage, the calendars are getting very filled. Call your agent, get on his or her calendar, and just, I would recommend, again, get signed up for something, knowing that you could still change your mind in the enrollment window. So sometimes I worry unnecessarily, but I am concerned that there's going to be some people that maybe just are left without anything because of not being aware of it, or by not being able to get assistance before that December 7th window. I like people to know this too. People say, well, what if I pick a terrible plan? And the truth is you can't buy a terrible plan, okay? I mean, Medicare is highly regulated. The products are extremely scrutinized. You want to find the best one, and there are plans that aren't as suitable for one or another. But just know that you can't get a terrible plan. You can't get scammed. Every carrier wants to say we're way better than the others. There are differences, sure, but I think that's an important standpoint for everyone to know, okay? That's one of the things I think they've done well with Medicare, safeguarding the products. So, you know, I thank you for letting me come up here tonight and appreciate the hard work that all of you are doing. I can answer any questions or certainly open up for any comments. Yes, Dave?
Mike, I have one. If now this clinic that came into town from Mason City, is that gonna be out of the network, or if they bill us from Alcalay or Mason City, will that make a difference?
That's a great question. Did everyone hear Dave's question? Okay, good. And I wish I could give you something more definitive. A lot of it is going to depend on the product that I have. Some products will say that, you know, we've got a network here in Minnesota, but if you get billed from outside Minnesota, as long as the provider takes Medicare, you're fine. Other ones aren't quite so open. So I think that will be also a good thing to keep in mind is provider access, you know. So, yeah, thanks, Dave. And thanks for the help with the screen too, Dave.
That's all right.
All right.
Here to serve.
Yeah.
You can do it.
Yes,
I have a question on the screen right before this one.
okay.
Down a little bit, it was about the Medicare Advantage window from January 1st to March 31st.
Yes, yes. I'll read this and then just talk through it a little bit. It says, what is this Medicare Advantage window from January 1st to January 31st? Or excuse me, March 31st, thank you. Besides the regular annual open enrollment, then for those who have a Medicare Advantage plan, they're giving a one-time chance to change it in that window referenced there. It kind of takes the place of, and in my opinion, improves what used to be called the Medicare Advantage disenrollment period. So I brought a little cheat sheet as well that I could read all the different mechanics of it, but that's what it is, so thank you. Any other
Minnesota won 23 to 21.
Okay, we can all go home now.
Yeah. And since my presentations never end with applause, I'm going to end it right now. Thank you.